Hi everybody and welcome to our module on sodium disorders. Sodium disorders are different from other electrolyte disorders because in general these are problems that have to do with water and not sodium. For example, when patients are hyponatremic, it means there is too much water relative to sodium, and when patients are hypernatremic, it means there is too little water in the plasma. As we will see in this module, the predominant symptoms in both hypo and hypernatremia tend to be those that involve the brain. When there's low sodium, this leads to a low plasma osmotic pressure because sodium is a very important osmole in the plasma. This means that fluid will leave the plasma and go into tissues and the brain will swell, and that leads to many of the symptoms of hyponatremia. Conversely, when there is high sodium in hypernatremia, there is high plasma osmotic pressure. This leads to fluid being drawn out of tissues and the brain shrinks, and that also leads to many of the symptoms of hypernatremia. So we'll begin by talking about hyponatremia or low plasma sodium. This tends to be more confusing for students than hypernatremia. Hyponatremia has a diverse set of potential causes and a number of tests that are typically done. So first of all, let's talk about the symptoms. And as I said on the last slide, when you have hyponatremia, fluid will move into tissues and the brain will swell, and that leads to the symptoms like malaise, stupor, and coma, and nausea as well. There are three key diagnostic tests that are important for all sodium disorders, but especially hyponatremia, and we're going to talk about all of these in the next few slides. The first one is the plasma osmolality, the second is the urinary sodium level, and the third is the urinary osmolality. The plasma osmolality is a measurement of the amount of osmotically active solutes that is present in the plasma, and one of the most important osmotically active solutes is sodium. When the sodium level is low, the osmolality should also be low. That's because sodium is a key contributor to the osmolality. So you can always remember that osmolality should be low in hyponatremia, and these two words rhyme, and that always makes it easy to remember. And the first step in evaluating a patient with hyponatremia is to make sure that the plasma osmolality is low as it should be. You can calculate the serum or the plasma osmolality using the equation I've shown on the screen. It's equal to 2 times the sodium concentration plus the glucose concentration divided by 18, plus the BUN divided by 2.8. And the normal value is 285 in the range of 275 to 295. Now, a couple of important things about this equation. Notice that sodium is the most important driver of the serum osmolality. A rise in the sodium level by 5 or 10% will create a significant increase in the serum osmolality. On the other hand, the glucose concentration is divided by 18 and the BUN divided by 2.8, so changes in those values have a lesser effect on the serum osmolality. I also want to point out that you'll notice that albumin is not in the equation for serum osmolality. That's because albumin is a very minor contributor to the plasma osmolality. Where albumin is much more important is inside the capillaries because it cannot cross the capillary membranes. In some of the cardiology modules, I talked about oncotic pressure, which is the pressure created by proteins like albumin, and they are very important in the capillaries in opposing hydrostatic pressure, but they don't play a major role in determining the serum osmolality, as you can see from this equation. So like I told you before, in a patient who is hyponatremic, you should have a low plasma osmolality. However, there are a couple of situations where you can have hyponatremia with a high plasma osmolality. Let's talk about what those are. So this can occur in hyperglycemia or in patients who have received the osmotic diuretic mannitol. Both glucose and mannitol are powerful osmoles, so they can raise the plasma osmolality. When they do this, they will draw water out of cells and dilute the sodium levels so that you will develop hyponatremia. And these are the two circumstances you should be aware of where you can develop hyponatremia with a high plasma osmolality. There are a couple of situations where you can develop hyponatremia with a normal plasma osmolality. This occurs when there are substances in the plasma that interfere with sodium measurement in the laboratory. In other words, this is not true hyponatremia. It's an artifact created by certain substances in the plasma. This can occur when lipid levels are very high. It can also occur when there are very high protein levels in the plasma, as you can get in patients who have multiple myeloma. This is often called pseudo-hyponatremia because it's an artifact in the measurement of the sodium level. So as I told you previously, the first step in evaluation of hyponatremia due to unknown cause is to check the plasma osmolality. If it is high, there is some osmole in the plasma that is pulling water out of cells and diluting the sodium level, and that can be in the settings of high glucose level or in a patient who has received mannitol. If the plasma osmolality is normal, then there's something in the plasma that's interfering with the measurement of the sodium level, and that could be lipids or proteins. Usually, however, it's going to be low, and what we're going to talk about in the rest of this module is the further workup that you do when the patient has low sodium level and a low plasma osmolality. So now let's talk about the other tests that are useful in hyponatremia. The second one is the urinary sodium level. Usually the urinary sodium level is greater than 20 milliequivalents per liter. However, in actuality, there is no normal urinary sodium level, and that's because this level varies with dietary sodium and free water in the urine. Remember that all the sodium you consume in your diet in a day must be excreted. So if you consume very little, you can have a low urinary sodium. If you consume lots of salt, you can have a high sodium. In addition, the amount of free water that you consume every day must be excreted, and this can also alter the urinary sodium level. However, this test is important in working up hyponatremia because a low value suggests either low sodium intake or excess free water, as we will talk about in the next few slides. And then the final test that's helpful in evaluating hyponatremia is called the urinary osmolality. We talked before about measuring the osmolality of plasma. Now we're going to talk about performing that measurement on the urine. So this is a measurement of the concentration of all osmoles in the urine, substances like sodium and chloride and potassium and urea. It's a very helpful test in hyponatremia because it varies with water ingestion and also urinary concentration. So for example, when the urinary osmolality is low, this means that the kidneys are excreting a very dilute urine. There's lots of free water in the urine, and that can be helpful in determining the cause of hyponatremia. When there's a high urinary osmolality, this means the urine is very concentrated. It's got relatively little free water, and the body is holding on to fluid and not excreting it in the kidneys. So now we've talked about the three clinical tests that are helpful in working up hyponatremia. We talked about plasma osmolality, urinary sodium, and urinary osmolality. But what you need to understand is what's controlling the results you get on those three tests is the level of antidiuretic hormone, which we don't measure directly, but it is working behind the scenes and it is determining the osmolality that you get in the urine and in the plasma, as well as the sodium level in the urine. As you probably know, antidiuretic hormone is often called ADH. It's also sometimes called vasopressin. The osmolality of the serum is sensed by the hypothalamus, and then ADH is released by the posterior pituitary gland in order to manipulate the plasma osmolality. When ADH is released, it leads to free water resorption by the kidneys, and this can affect the plasma osmolality. Shown on this slide are two flow diagrams to help you understand how the body responds to water intake to maintain normal sodium levels and normal plasma osmolality. If you consume excess water, there is a fall in the plasma osmolality. The posterior pituitary will respond by decreasing the amount of ADH released. This will lead to less water resorption by the kidneys and more water excretion by the kidneys, and that will dilute the urine and decrease the urinary osmolality. And note that I've bolded the change in the ADH level and the change in the urinary osmolality. These are the types of things they like to ask you on your exams. On the other hand, if you restrict the amount of water that you consume, this will raise the plasma osmolality, and the posterior pituitary will respond by increasing the amount of ADH released. This will lead to increased water resorption by the kidneys and less water excretion. That will concentrate the urine and raise the urinary osmolality. A key point about ADH that you need to appreciate is that any cause of high ADH can lead to hyponatremia. Remember that ADH controls the serum sodium level and the plasma osmolality. So if ADH is always high, then sodium is no longer being controlled by ADH. When your ADH level is always high, it means that your sodium level is going to be determined by the amount of free water you take in, and most of us take in more free water than we need. This means that when you increase your intake, you can dilute your plasma and become hyponatremic. And as we will see, there are a number of clinical scenarios where the ADH level is always high, and these very easily lead to hyponatremia. Just a couple of general points, and then we'll get into specific causes of hyponatremia. In the setting of hyponatremia, if the body is responding appropriately, the urine should be diluted. The kidneys should be excreting free water, and there should be more free water than solutes in the urine, thus the urine should be dilute. This means that the urine osmolality should be low, and in addition, you may see a low urinary sodium. However, remember that the urinary sodium varies to some degree with the dietary intake, so it's not as reliable a marker as the low urinary osmolality. What this means is if the urine is diluted in the setting of hyponatremia, then the kidneys are responding appropriately. It means the ADH level is low, as it should be, and the cause of the hyponatremia must lie outside the kidneys. And we will see that there are a couple of reasons why you can get hyponatremia even if the kidneys are responding appropriately. On the other hand, if the urine is not diluted, it means the kidneys are not responding appropriately. Either there is too much ADH for some reason, or drugs or pathology are interfering with the kidney function. So these two principles are very important. They can help you understand all the causes of hyponatremia that we'll talk about on the next few slides. Now let's talk about specific causes of hyponatremia. If you look up the causes of hyponatremia, you will find a very long list. So I've always found it helpful to group them into categories. The first category is heart failure and cirrhosis. The second is when the kidneys are ineffective. The third group of causes are those that lead to high ADH levels, and finally, there's a special group which includes psychogenic polydipsia and dietary causes. The first two causes of hyponatremia are heart failure and cirrhosis. Now, in both of these disorders, patients are swollen. They have too much total body water. As you may know, in heart failure, patients can have lower extremity edema and swollen neck veins and pulmonary edema. In cirrhosis, patients can have ascites and lower extremity edema as well. So in both of these conditions, there are clinical signs of hypervolemia. However, what is happening inside the vascular space is that the body is perceiving hypovolemia. So there's a disconnect. There's real actual hypervolemia, but the body is perceiving hypovolemia. The reasons are a little bit different in heart failure and cirrhosis. In heart failure, this happens because there's a decrease in the cardiac output. In cirrhosis, this happens because of low vascular resistance and vasodilation. But in both conditions, the body thinks there's hypovolemia, even though there is actually hypervolemia. When the body perceives hypovolemia, ADH will be released. So ADH levels become high. This is called the non-osmotic release of ADH. I talk about this in the video on nephron physiology, but normally ADH levels go up and down based on the serum osmolarity. However, ADH levels will also go up when the body perceives hypovolemia to a significant degree. This is a life-saving mechanism. It's called the non-osmotic release of ADH, and it occurs only when the body perceives low intravascular volume, and that happens in heart failure and cirrhosis. So because ADH levels are going to always be high in both of these conditions, it's very easy to develop hyponatremia. If a patient just consumes a little bit too much water, the plasma sodium will become diluted and hyponatremia will occur. And importantly, if you look at the urine, it will not be diluted. The urinary osmolarity will be high, and that's because there's lots of ADH around, all being triggered by the non-osmotic release of ADH from the pituitary gland as a result of perceived hypovolemia, even though there is actual hypervolemia. Somewhat confusing, but think about it for a minute until you get this straight in your head. The second setting where hyponatremia can occur is when the kidneys are ineffective, and this can be seen in advanced renal failure patients. When there is advanced renal failure, the kidneys cannot excrete free water normally. This means that the urine cannot be diluted. Therefore, the minimum urinary osmolarity that the kidneys can produce will rise even in the setting of very low ADH. When ADH levels are low, normal kidneys will produce a very dilute urine with a urinary osmolarity that is less than 100. However, in patients with advanced renal failure, the minimum urinary osmolarity can rise to the 200 to 250 range, even in the setting of very low ADH. And a key point here is that high urinary osmolarity in the setting of hyponatremia indicates an abnormal response to the low sodium levels, and that means there is a problem with the kidneys. And then finally, you might think that if the kidneys cannot excrete free water, the patient would have signs of hypervolemia, like lower extremity edema and elevated jugular venous pressure. However, it turns out that in clinical practice, hypervolemia is not a reliable sign in the setting of advanced renal failure, and patients can develop hyponatremia even when they appear euvolemic on clinical exam. Another circumstance in which ineffective kidneys can lead to hyponatremia occurs when drugs are administered that interfere with renal function. This can occur in patients taking diuretics. As you may know, diuretics cause sodium and water loss, and therefore they can disrupt sodium and water balance and lead to hyponatremia. The classic type of diuretic to do this are the thiazides. They are famous for causing hyponatremia. We'll talk about why that is the case in a minute. However, you can also develop hyponatremia after administration of a loop diuretic. One thing to be aware of is that in patients who develop hyponatremia from diuretic therapy, the urinary findings, like the urinary sodium and osmolality, are highly variable. There are a couple of reasons for this. First of all, the drugs promote sodium and water excretion. Secondarily, they cause patients to become dehydrated, and this stimulates ADH release. And then finally, the amount of water and sodium in the urine vary by the dose of the drug and the dietary intake. So for all of these reasons, the urinary findings are highly variable. So in clinical practice, the way you diagnose hyponatremia secondary to diuretic therapy is to discontinue the drug and see if it improves. Now let me explain why thiazide diuretics much more commonly cause hyponatremia compared to loop diuretics. Recall that loop diuretics block sodium resorption in the thick ascending limb. This means that more sodium will go to the collecting duct and therefore go out in the urine. It also means that the osmolality in the collecting duct will be higher and therefore less water will be drawn out. However, there is a second effect of loop diuretics that you need to always remember, and that is that when you administer a loop diuretic, you diminish the osmolality out in the medulla. The pump that is inhibited by loop diuretics is responsible for maintaining much of the high osmolality out in the medulla. So when it is inhibited, the osmolality in the medulla falls. This means that you have a much lower driving force to remove water from the collecting duct, And this is why loop diuretics are such powerful diuretics. They send lots of water out in the urine. What this means is that in the setting of a loop diuretic, it's very hard to reabsorb too much water and become hyponatremic, and that is because these gradients have been diminished by the drug. Contrast that with thiazide diuretics. In patients taking thiazide diuretics, sodium resorption is blocked in the distal tubule. This means that the osmolality in the collecting duct will rise, more sodium goes out in the urine, and there is slightly less water that is resorbed. However, thiazide diuretics leave the medullary osmolality completely intact. This means that patients taking these drugs continue to maintain the ability to absorb lots of water. This is a setup for hyponatremia. You're sending sodium out in the urine, but your ability to reabsorb free water remains intact, and thus the tendency to develop hyponatremia is much higher in patients taking thiazide diuretics. I've summarized these points on this slide. In patients taking loop diuretics, the medullary gradients are diminished. This makes it difficult to reabsorb free water, and this is why loop diuretics are powerful diuretics. This also means there's a low likelihood of resorption of excess free water leading to hyponatremia. Contrast that with thiazide diuretics where the medullary gradients are intact. This means the nephron has an intact ability to absorb free water. More sodium will go out in the urine after administration of a thiazide diuretic. This is responsible for its diuretic effect. However, there is a higher likelihood of resorbing excess free water because those medullary gradients are intact, and thus a higher risk of hyponatremia seen in patients taking thiazide diuretics. A third group of causes of hyponatremia are those related to high ADH levels. So for starters, any cause of dehydration can lead to low intravascular volume, and this can stimulate ADH release from the posterior pituitary. So for example, patients who have vomiting or diarrhea or patients who are sweating a lot can have high ADH levels. And as we talked about before, when the ADH level is high, the sodium level varies with water intake. So if you take in lots of free water, this can lead to hyponatremia. And this is one of the reasons that athletes drink Gatorade instead of water, because Gatorade replenishes not only the fluid that they've lost, but also the electrolytes that they've lost. Adrenal insufficiency is a well-described cause of hyponatremia that works via high ADH levels. I talk about adrenal insufficiency in detail in the endocrine modules, but for our purposes here, cortisol normally suppresses ADH release. So the loss of cortisol in primary or secondary adrenal insufficiency can lead to high ADH levels. In addition, in primary adrenal insufficiency, there's also a loss of aldosterone secretion. This can lead to salt and water loss through the kidneys, and that can raise ADH levels by depleting intravascular volume. Hypothyroidism is also a classic cause of hyponatremia. It's believed to be related to high ADH levels that occur when thyroid hormone levels are low. And then a final cause of hyponatremia related to high ADH levels is SIADH, so let's talk about that now. SIADH is the syndrome of inappropriate antidiuretic hormone secretion. In this syndrome, too much ADH is released inappropriately, that's how it gets its name, and this leads to hyponatremia. In this setting, the urinary sodium will be high, usually greater than 40 milliequivalents per liter, and the urinary osmolality will also be high, usually greater than 100. And both of these findings should make sense to you. The urine is being concentrated because ADH is inappropriately elevated and free water is being reabsorbed by the nephron. Importantly, if you want to make a diagnosis of SIADH, you have to exclude all other causes of high ADH, such as the ones we've talked about in the last few slides. So you can't make a diagnosis of SIADH in a patient who has heart failure, cirrhosis, dehydration, or thyroid and adrenal disease. All of these things have to be excluded before you can say that a patient has hyponatremia due to SIADH. There are a number of clinical scenarios where SIADH is commonly seen. The first is in association with certain drugs. There's a long list of drug causes of SIADH. Two of the classic ones are carbamazepine, which is a seizure drug, and cyclophosphamide, which is an immunosuppressant. SIADH can also occur as a paraneoplastic syndrome, especially in small cell lung cancer. Certain cancers like small cell lung cancer can produce ADH and lead to SIADH. Many different central nervous system diseases stimulate ADH release and lead to SIADH. This can be seen with strokes and brain bleeds and brain tumors. And then finally, pulmonary disease of just about any cause can also lead to SIADH. The mechanism of this is not entirely clear. Now, you would think that in patients with SIADH, they would appear fluid overloaded on clinical exam, that they would have crackles in their lungs and lower extremity edema, all from the excess fluid the kidneys are retaining. However, it turns out that in patients with SIADH, they have a normal volume status when you examine them clinically, and it's very important that you understand why this is the case. So in SIADH, there is fluid retention due to high ADH levels. However, the body responds by dialing down the renin-angiotensin-aldosterone system. The lowering of aldosterone levels leads to more sodium going out in the urine. This worsens the hyponatremia. However, the lowering of the aldosterone levels also decreases the water reabsorption by the kidneys, and this prevents patients from becoming fluid overloaded, and that is why patients with SIADH have a normal volume status. A classic question on rounds in the ICU is for a medical student or an intern to be asked for the diagnostic criteria of SIADH. So let's go over that now. First of all, you have to have hypotonic hyponatremia, meaning you must have reduced plasma osmolarity and reduced plasma sodium. Liver, cardiac, and renal function must be normal, which excludes these organ systems as causes of hyponatremia. The patient must be clinically euvolemic, meaning there's no evidence of fluid overload like edema or rales or elevated neck veins. The thyroid and adrenal function must be normal. And then finally, the urine osmolality has to be greater than 100. This implies that the urine is not maximally dilute. Remember, in hyponatremia, the urine should be maximally dilute, indicating the kidneys are dumping as much water as possible. Maximally dilute urine has an osmolality of about 50 or so, so if the urine osmolality is greater than 100, that implies something is wrong, and that's one of the criteria for SIADH. The treatment you will most commonly see employed for SIADH is fluid restriction. Remember what I told you before, when the ADH level is high, you retain most of the free water that you drink. That's how you can become hyponatremic. However, if you restrict the access to free water, then the sodium concentration will slowly rise over time, simply because you are taking in less free water. There is, however, a special treatment option for SIADH that's sometimes used. That's demeclocycline. This is its structure shown on the screen. It's a tetracycline antibiotic, but it is also an ADH antagonist, and thus it can raise the sodium concentration in patients with SIADH. Our next cause of hyponatremia is psychogenic polydipsia. Your kidneys can excrete a lot of free water. However, there is a limit. If you drink more than 18 liters of water per day, you can develop hyponatremia because your kidneys cannot excrete all of this fluid. And this occurs in psychiatric patients who are compulsive water drinkers. They become hyponatremic, and importantly, their urine osmolality is low, less than 100. This indicates the kidneys are working. They are trying to eliminate the free water. The problem is that the patient is drinking more free water than the kidneys can handle. And it's very easy to fix this problem. You restrict the access to water, and then the hyponatremia will resolve. There are a couple of special diets that can lead to hyponatremia, and the common theme in all of these diets is that there is very little sodium ingestion. Now, this is counterintuitive. You might think that consuming too little sodium should not cause hyponatremia, but it can, and the reason is because the kidneys need some solutes in order to excrete free water. I'll explain this to you in the next few slides. So one of these diets is called the tea and toast diet. This happens when people are trying to lose weight and they eat very little solid food, and as a result, they consume very little sodium. In addition, some beer drinkers consume very little sodium. This is called beer potomania when beer drinkers develop hyponatremia. The reason is because they are getting all their calories from beer and they're not consuming enough sodium. The reason that very little sodium ingestion can lead to hyponatremia is because there is a minimum urine osmolality of about 60 milliosms per kilogram that the kidneys must maintain. This means that the kidneys always have to excrete some solutes with free water, and therefore if you consume very little solutes, in other words, very little sodium, that will limit the amount of free water that you can excrete. And then if you intake more free water than the kidneys are capable of excreting, this can lead to hyponatremia. To make this more clear, let's go through the thought experiment I've shown on the screen. So the salt that you consume in your diet must equal the salt excreted. And let's imagine that the highest water to salt ratio that the kidneys can achieve is 10 to 1. In a patient on a normal diet who consumes 3 units of salt, that patient can excrete 30 units of water and still abide by the 10 to 1 ratio required by the kidneys. In a patient on a restricted diet who only consumes 1 unit of salt, they can only excrete 10 units of water. In other words, the water excretion is being limited by the tiny amount of salt in their diet. And this occurs because the kidneys must excrete some salt with water. So if you consume very, very little salt, that can limit the amount of water that you can excrete, and thus you can develop hyponatremia. Here's another way to look at this. A patient eating a normal diet consumes about 1,000 milliosms per day of solute. If the most dilute urine that the kidneys can produce is 50 milliosms per liter, this means the maximum free water output for a patient on a normal diet is 1,000 divided by 50, or 20 liters per day. That is a lot of free water. It is very hard to develop hyponatremia when your kidneys are capable of excreting 20 liters a day of free water. On the other hand, a patient consuming one of these special diets we're talking about now might eat only 250 milliosms a day of solute. Just like normal patients, the most dilute urine for these patients is 50 milliosms per liter. This means the maximum free water output for a patient on a special diet is 250 divided by 50, or 5 liters a day. It now becomes much easier to consume an excess of free water when you can only excrete 5 liters per day. And if the water intake exceeds 5 liters per day, That will lead to hyponatremia. If low sodium in the diet is leading to hyponatremia, the urine will have a low osmolality, less than 100. This indicates the kidneys are working. They are trying to eliminate free water. The problem is they can only get rid of so much free water because they are limited by the small amount of salt. In other words, the small amount of solute availability to go out with the urine. So many textbooks like to divide hyponatremia by the volume status of the patient. So I've done that for you on the slide here. So cirrhosis, heart failure, and some patients with renal failure can be hypervolemic and have signs on physical exam of excess volume like lower extremity edema and crackles and increased jugular venous pressure. Hypovolemic hyponatremia occurs when patients are dehydrated, when they're on diuretics, or where they have primary adrenal disease where they have lost their aldosterone secretion by the adrenal gland. And then euvolemic hyponatremia has a number of causes, including SIADH, which we talked about as a diagnosis of exclusion, also hypothyroidism, secondary adrenal disease, some patients with renal failure, and finally polydipsia and dietary causes of hyponatremia. In patients who have euvolemic hyponatremia, measurement of the urinary osmolality is very helpful. If the urinary osmolality is low, this means the kidneys are responding appropriately and trying to excrete free water. And this is what you see in psychogenic polydipsia and also in the dietary causes like the tea and toast diet and beer potomania. If the urinary osmolality is high, this means the kidneys are not responding appropriately. This can be because the ADH level is high from SIADH or from hypothyroidism, or it can be because the kidneys are failing and they are unable to dilute the urine. In hypovolemic hyponatremia, where patients appear dehydrated on physical exam, measurement of the urinary sodium can be helpful in differentiating the causes. That's because a low urinary sodium will be seen in many of the extrarenal causes of hypovolemic hyponatremia. When patients are vomiting or they have diarrhea or they are sweating, in addition to losing water, they lose lots of salt in the fluids in all of these circumstances. This leads to a very low urinary sodium level. On the other hand, if the urinary sodium is high, such as greater than 30, this usually means there is some renal-related cause of the fluid and salt loss. So for example, patients on diuretics can have lots of sodium in the urine because the diuretics block resorption of sodium. Patients who have primary adrenal disease have low aldosterone levels. This also leads to more sodium in the urine. On your exams, you're often asked for the expected changes in ADH levels and urinary osmolality for a given cause of hyponatremia. So all of the disorders I've bolded in red on the screen are associated with increased ADH levels and increased urinary osmolality. In cirrhosis and heart failure, ADH levels are high because of intravascular volume depletion, and this will concentrate the urine and raise the urinary osmolality. In dehydration and diuretic use in patients with primary adrenal disease, the intravascular volume is also low. This raises the ADH level and concentrates the urine. And then finally, in these causes of euvolemic hyponatremia, the ADH level is high, so that also will concentrate the urine. There are just two disorders where the ADH level is low and the urinary osmolality is low. That's polydipsia and the dietary causes. In both of these situations, the kidneys are responding appropriately. They just cannot excrete the free water adequately. And then finally, renal failure is very unusual in that the ADH level is low, but the kidneys are unable to respond by diluting the urine, and thus the urinary osmolality is high. We talked before about treatment of hyponatremia from SIADH, but now I'll mention treatments for other causes of hyponatremia. Just like in SIADH, fluid restriction alone can often be helpful to raise the serum sodium. Sometimes concentrated saline, 3% saline, can be used. And then finally, there are drugs called Vaptan drugs like tolvaptan and conivaptan. These block ADH, and they've been shown to be effective in treating hyponatremia associated with heart failure only. When you are treating a patient with hyponatremia, you have to be very cautious in raising the serum sodium level because you can cause permanent brain damage and even death. Raising the serum sodium level too quickly can lead to central pontine myelinolysis, which is also called the osmotic demyelination syndrome. This is associated with overly rapid correction of hyponatremia, usually raising the serum sodium more than 10 milliequivalents per 24 hours. Through a poorly understood mechanism, if you raise the sodium too quickly, it leads to demyelination of central pontine axons. This causes a lesion at the base of the pons, and patients lose their corticospinal and corticobulbar tracts, which are the major motor tracts in the pons. This leads to a quadriplegia that can be similar to the locked-in syndrome, and it can lead to death. And for this reason, in clinical practice, when you are treating a patient with marked hyponatremia, you carefully monitor the serum sodium level and don't let it go up more than 10 milliequivalents per 24 hours. So now we'll switch gears and talk about the opposite problem, which is hypernatremia. This is where the serum sodium level is too high. Just like hyponatremia, many of the symptoms relate to central nervous system dysfunction. The symptoms of severe hypernatremia include irritability, stupor, and coma. You can basically divide the causes of hypernatremia into two major groups. The first group are those causes related to water loss. When you lose fluid, especially from the skin in sweat and the lungs in water vapor, you lose much more water than sodium. If you aren't drinking free water, this can lead to hypernatremia. In this setting, the ADH level will be high and the urinary osmolality will be high. The body is responding by concentrating the urine and retaining free water. It's just not able to retain enough water to replace that which has been lost in the skin and in the lungs. The second group of causes fall under the heading of diabetes insipidus. Diabetes insipidus occurs when there is loss of ADH activity, and it can be either central or nephrogenic. A central cause means there's loss of ADH release from the pituitary, and this can occur when there's central nervous system damage, such as in trauma or in tumors of the central nervous system. There's a rare nephrogenic form of diabetes insipidus that is congenital, where babies are born unable to respond to ADH. And then finally, there are a number of so-called acquired nephrogenic causes of diabetes insipidus, where for one reason or another, the kidneys become unable to respond to ADH, and this leads to hypernatremia. In certain electrolyte disorders, nephrogenic diabetes can occur. When patients have hypercalcemia or hypokalemia, the kidneys can become poorly responsive to ADH, and that can lead to diabetes insipidus. In addition, there are a number of drugs that are associated with nephrogenic diabetes insipidus. I've listed two of the classic ones on the screen. Lithium, which is a psychiatric drug, and amphotericin B, which is an antifungal drug, are both classically associated with development of diabetes insipidus. The symptoms of diabetes insipidus are polyuria and polydipsia. When there is a lack of response to ADH or a lack of ADH, the kidneys excrete excessive free water. This leads to polyuria. The patient then gets dehydrated and therefore they are thirsty all the time, and that's polydipsia. And these are the same symptoms as diabetes mellitus. That's why it's called diabetes. Diabetes mellitus, as you may know, is caused by glucose in the urine. And years ago, when people tasted the urine of patients with diabetes mellitus, it was sweet. Therefore, they named it diabetes mellitus. The word mellitus means sweet. Diabetes insipidus, which has similar symptoms, although a completely different mechanism, had tasteless urine, and therefore it was called diabetes insipidus. The word insipid means lacking taste. Let's talk about how you diagnose diabetes insipidus. You suspect the condition when a patient has polyuria and polydipsia. Now, I've listed diabetes insipidus among the causes of hypernatremia, but in many cases, the plasma sodium level is actually normal. That's because water loss stimulates thirst and patients replace the water that they are losing. Hypernatremia only occurs if they don't drink enough water, and this is more common in patients who have a central cause of diabetes insipidus. The central lesion can affect the central nervous system and impair the thirst mechanism. And then finally, when you check the urine osmolality in patients with diabetes insipidus, it will be low, usually in the range of 50 to 200 milliosmoles per kilogram. This indicates that the kidneys are dumping free water and therefore the urine is very dilute. Once you suspect the disorder based on polyuria and polydipsia and a dilute urine, you then ask the patient to restrict fluid. After 8 hours of no free water intake, the urine should become concentrated. If it remains dilute, this means there is absent or ineffective antidiuretic hormone. You can then administer an analog of ADH, either vasopressin, which is ADH itself, or desmopressin, which works like ADH, and this should concentrate the urine if the kidneys are able to respond. If the kidneys do not respond, it means the patient has nephrogenic DI, and the problem is that the kidneys are unable to react to ADH. If there is concentration of the urine, it means the patient has central DI and there's a loss of ADH release from the pituitary for some reason. The treatment of hypernatremia is usually water, ideally PO. In patients who are able to drink, you simply encourage them to consume free water. You also can administer intravenous fluids that lack sodium. There are fluids called D5W, which contain dextrose, so that they are isotonic with plasma but do not contain sodium. Patients with central DI can be treated with desmopressin. I mentioned this earlier. It's an ADH analog. It has no vasopressor effect like vasopressin, so it won't raise the blood pressure. The problem with vasopressin is although it replaces the lost ADH in diabetes insipidus, it's also a vasopressor. That's how it gets its name. So it will constrict the blood vessels and raise the blood pressure. That won't occur with desmopressin, and that's why it's a nice treatment for diabetes insipidus. There are two special therapies that can be used in nephrogenic diabetes insipidus when the kidneys are unable to respond to ADH, and those are thiazide diuretics and nonsteroidal anti-inflammatory drugs. The mechanism of thiazide diuretics is counterintuitive. You might think, why give a diuretic to a patient who has polyuria? But it turns out that thiazide diuretics can be helpful. This is because they cause a mild state of volume depletion, And this leads to an increase in proximal tubule resorption of sodium in water. In other words, more water is pulled out of the nephron in the proximal tubules in patients taking thiazide diuretics. This means less water is delivered to the collecting tubules, and as a result, there is a paradoxical antidiuretic effect in the setting of nephrogenic diabetes insipidus. NSAIDs work, as you may know, by inhibiting the synthesis of prostaglandins. This is helpful in the kidneys because prostaglandins are ADH antagonists, and thus when you administer an NSAID, you can see an improvement in the symptoms of polyuria and polydipsia. And that concludes our module on sodium disorders.